Hey, thank you so much. I'm excited to be here. I'm Brittany Bruggeman, and the research I'm going to talk about today was funded by the Georgia Center for Diabetes Translation Research, and it really was a passion project of mine, and we'll kind of get into a few of the reasons why. Um, so let's see here. The only disclosure I have is that I have past research funding from Tandem Diabetes Care. So today we're going to talk about disparities in diabetes technology use. We'll talk about barriers to the clinician prescription of diabetes technology, both to the general population and specific at-risk groups using a social ecological framework. And we'll talk about ways in which changes to the electronic health record could facilitate diabetes technology prescriptions. So we know that the use of diabetes technology, specifically automated insulin delivery systems, continuous glucose monitors, and insulin pumps, improves the management of diabetes and leads to improved quality of life and improved glycemic control. And encouragingly, patients who actually have the highest A1C levels have the most improvement in these measures when they start on diabetes technology. The ADA 2025 standards of care, which are out and available for you to read, recommend use of continuous glucose monitors for all people with diabetes on insulin. And it recommends automated insulin delivery systems as the preferred insulin delivery method for type 1 diabetes. And it also says that we should be offering insulin pumps to people with type 2 diabetes on multiple daily injections of insulin. Both of these recommendations do have the caveat that patients should be capable of using the device safely. And we'll discuss some of my opinion on the impact of this language later on in the talk. So despite being pretty universally beneficial, disparities do exist in diabetes technology use by race, ethnicity, and insurance status. Within the Type 1 Diabetes Exchange Quality Improvement Collaborative, which is this huge cross-country quality improvement collaborative involving many, many clinics, really trying to improve the care that we deliver to people with Type 1. They looked at data in 2021 and 2022, and that data showed that non-Hispanic white patients were using pumps and hybrid closed-loop systems, which is another term that we use sometimes for automated insulin delivery systems. And these are just systems where an insulin pump and a continuous glucose monitor talk to each other and kind of can titrate insulin levels up and down. But the non-Hispanic white patients were using these technologies at a rate twice that of non-Hispanic Black patients. And there was a 14% gap by private and public insurance status. In my opinion, this, and has been detailed by the American Diabetes Association as well. This lack of technology use can also lead to therapeutic inertia in these patients. If any of y'all out there are diabetes clinicians, how this works is a patient will come into clinic for their 3-month follow-up of their diabetes, and we'll say, okay, what are your glucose levels? And they'll say, oh no, I forgot my my meter at home, my blood sugar meter. And so we won't have any data to kind of help us titrate our therapeutics. And so it's really important for us to have data. And the nice thing about continuous glucose monitors is data is actually uploaded to the cloud automatically. And so it's pretty easy for us to get the data, just from the cloud. And so when people have, these continuous glucose monitors and insulin pumps, it's a lot easier to titrate insulin dosing in a data-driven and actionable way, and timely way, because we just have better access to data. And rather than a couple of points per day that we would get from a blood sugar meter, we have, a data point every 5 to 10 minutes from these types of technologies. And so, this really can lead to therapeutic inertia for patients if they don't have access to these technologies. And concerningly, several studies have found that clinician actions play an important role in perpetuating these disparities. In 2021, Dr. Walker and colleagues at the University of Florida and Stanford conducted focus groups among high-risk adult patients. And they defined high risk as they had either had DKA, diabetic ketoacidosis, had a hemoglobin A1C greater than 9%, or received care at a federally qualified health center, which are health centers kind of for underserved patients that are subsidized by the government where they can get free or reduced cost care. Provider level barriers were unfortunately the most reported barrier to use of diabetes technology by these patients, which really made my heart kind of sink when I was reading this as a diabetes care provider. This included clinicians who had unclear criteria for receiving a pump or a continuous glucose monitor, or clinician judgment or lack of understanding. I found the semi-structured interview quotes to be helpful and impactful. So the first one says, "I would prefer an insulin pump because I think it would help me control my diabetes, but since I've been deemed uncontrollable, chances I can't get one." So this is kind of that paradox where, having the technology would help to improve things, but because you, are having a hard time, you can't get the technology. The second, to paraphrase, says, "Every time the endocrinologist says you have to give them 3 months of records, I give it to them. They then say you're doing so well that you don't need it. And that's not listening to what I need to maintain where I'm at. Right now, my A1C is at 11.5. They don't listen to you." And then we have a 2022 study that did an implicit bias assessment within providers in the Type 1 Diabetes Exchange Quality Improvement Collaborative, again, that showed that 61% of clinicians had what they called insurance-mediated implicit bias, which was basically, they gave patient examples and kind of case vignettes. And if they had Medicaid, the provider would be less likely to prescribe a pump or a continuous glucose monitor. So 61% of clinicians had that, and then 34% had racial and ethnic mediated implicit bias. So where do we go from here is kind of what I was thinking when I was designing my research project. What can we do to improve these barriers? Clinicians have a lot of power, so we can influence patient knowledge, attitudes, and access to diabetes technology. And then kind of on the more societal and policy level, we can advocate for helpful policies to promote access to our patients. However, when I was reading these patient perspectives, I was also seeing things from my own clinician's perspective and the barriers that I've personally faced in prescribing diabetes technologies. So we used a social ecological model that illustrates that our decisions regarding whether to prescribe diabetes technology emerge from a combination of individual, interpersonal, and systems level factors in which we all operate. So we're all operating when we're working every day within these systems, and they influence whether or not we're going to prescribe diabetes technology. So our team sought to identify the specific individual, interpersonal, and systems level factors, both facilitators and barriers to clinician prescriptions of diabetes technologies through surveys and semi-structured interviews. So we did both with 16 pediatric and adult diabetes clinicians, both at the University of Florida and then also within the Emory and Grady health systems. So had some Florida and Georgia representation there between January and May of 2024. The interviews were transcribed, coded, and analyzed by DataGain, which is an external qualitative analysis vendor. Recruitment for the study was part of a larger ongoing effort to develop an electronic health record dashboard aimed at improving prescription of insulin pumps and continuous glucose monitors for at-risk groups of diabetes patients. So here's the questions that we asked that I'll kind of discuss the results of today. So providers were asked regarding facilitators and barriers to prescribing insulin pumps and CGMs, which barriers were worse for those with low incomes, or enrolled in Medicaid, and in racial and ethnic minorities. They were also asked about specific requirements that they may have needing to be met for patients to qualify for a CGM or insulin pump, because this is something that was mentioned a lot by patients, is that their providers have these certain criteria they would have to meet to get insulin pumps or CGMs. So we kind of asked the reverse and asked about specific facilitators and barriers within the electronic health record, because Other studies have shown that clinicians spend over half of our time embedded within the EHR, and it really can make a big difference on what we do in our day-to-day. So we were specifically asking about the EHR as well. The participating providers that we had were 63% female, 63% non-Hispanic white, with 31% Hispanic or Latino. And then on the younger side, or I'm going to call it the younger side, at a median age of 39. 75% of the clinicians that we interviewed and surveyed were MDs, and most of the rest were APRNs and one PharmD. Half practiced adult endocrinology, and most of the rest practiced pediatric endocrinology. They were on the earlier side of practice, with half of them having practiced for 6 years or less, and were mainly part of large groups of diabetes care providers. So half of their patients had type 1 diabetes, which is, a bit unusual for diabetes care providers in the adult space, and half of their patients, 90% of their patients required insulin. I didn't quite finish that up. And so, sorry, advancing without meaning to. So these really kind of the summary, these providers were definitely highly specialized diabetes care providers who see a lot of type 1, have a lot of patients on insulin, and are on the younger side, and so should be pretty well versed in diabetes technology. There have been other papers showing that younger providers have a little bit of an edge when it comes to technology, not a huge one, but a little bit of an edge. And so, these should be really the people who are the best at prescribing diabetes technology. The providers estimated that 80% of their patients who qualified for CGM based on ADA guidelines that we kind of talked about before were using one, and only about half of their patients who qualified for an insulin pump were using one. So we'll talk about the survey results first, and then we'll talk about the interview results. From the survey results, the most common individual level barriers to CGM use that were reported from about half of providers were patients either being unable to keep the CGM on their skin, not wanting a device on their body, or having skin reactions or pain. So a lot of skin issues and not wanting devices on the body. Alarm fatigue was also reported as an individual level concern by about a third of providers. The patients not being interested in a CGM was the top barrier to regular use reported by one provider out of the 16. So not a huge number, but it was a big barrier to one, and was a top 5 barrier for about a third. Patient or caregiver concern about how the device was functioning or how it would function was also commonly reported by slightly less than half. Interestingly, providers did not see their own knowledge level about CGM placement, day-to-day use, or interpretation of CGM data as a barrier to patient use. And this, to me, I think it's probably because we are interviewing more specialized diabetes care providers. And so these people should have high levels of knowledge about CGM. Providers felt that patients not wanting diabetes devices on their body was more of a concern with insulin pumps. So that was really the highest concern for them on an individual level was for insulin pumps versus CGMs. It was really the device being on the patient's body and their concern over that. Over half thought this was a top 5 barrier. Similarly, patients not being interested in an insulin pump was reported as a barrier by half of providers, and the top barrier to use by one provider. The skin concerns and skin reactions or pain were also reported, but were less of a concern compared to CGMs. So really, people concerned about the visibility or just wearing something was the top concern for pumps, versus skin issues were more of the concern for CGMs. And then patient and caregiver interest and not being interested in an insulin pump was a higher barrier than in CGM. And then one of the 16 providers actually did report that their own knowledge of insulin pump placement and day-to-day use was a barrier to regular patient use of insulin pumps. When we look at the interview data, so 26% of codes were related to individual level barriers. Providers talked about, again, the patient's skin issues and that sort of thing came up, but even more of an issue was the patient's ability to afford diabetes technology. And this was sort of seen both as an individual and a systems level barrier. And we'll talk about how these barriers all kind of interact towards the end. But affordability was a huge thing, and patients specifically being able to afford it. And people with high deductibles or copays were specifically thought to be a major barrier. Similarly, the individual patient and family's ability to navigate the convoluted system of selecting a device and then getting insurance authorization, having it picked up or delivered by the DME company or pharmacy, and scheduling education and actually starting the technology. So having to go through all these steps was described as a barrier and something that exacerbates health disparities, since patients with more time and more resources are better able to navigate this convoluted system that we have going on. Again, the sight and skin issues were there, but maybe not quite as big of a concern in the interviews. And then, familiarity and trust in technology did come up, and then health literacy also came up as an important individual factor. One provider said sometimes just getting them to clinic, right? Higher no-show rates or transportation issues or missing work to be there are just barriers to them being in clinic for further discussions and conversations. For interpersonal barriers, on the survey, a third of providers reported that a patient or caregiver's inability to understand or use technology effectively was a barrier to regular CGM use. So I reported this as an interpersonal barrier because hopefully, that's part of our job in kind of educating patients to get them to the level where they can understand and use technology. And so if we're unable to get them there, I feel like that's a little bit of an interpersonal barrier. But that was a big barrier, and one felt that this was the biggest barrier to regular CGM use. Similar numbers were reported for regular pump use, which was interesting because insulin pumps are more complicated and do require more input and active use than CGM. But this may be because more patients actually qualify for the use of CGM per ADA criteria than insulin pumps. And so it may be that the wider population qualifying for CGM, some of them have lower health literacy potentially, and so they see it as more of a barrier. Lack of time and resources in clinic to educate patients on CGM and pump use were also reported as a major barrier for about 1 in 5 providers. From the interview results, 7.5% of the codes were related to interpersonal barriers, so the lowest amount among the 3 kind of coding systems that we had. These included communication challenges from language and cultural barriers. So a lot of us have issues with getting interpreters, and that was definitely shown in the interviews. A facilitator was having clinicians make a conscientious decision to prescribe to anyone who qualifies, using shared decision-making models, and having adequate visit time, translators, and educational resources. But overall, 43% of participants did describe that potential patient safety issues from low health literacy could warrant a decision to not prescribe certain technologies. These included, providers were concerned that some patients couldn't monitor their symptoms consistently, follow instructions, or comprehend basic math. This specifically impacted the decision to prescribe insulin pumps. So I included one of the more positive views on this, but there were a variety of views in terms of health literacy and just overall literacy and being able to use an insulin pump. So it says there are some patients who still struggle with connecting the pieces even when you show it, but I would say that's more like the exception to the rule. And I think if the time and resources are available to educate the patients, that a lot of that gap, even with issues of health literacy, a lot of that gap can be overcome. And finally, as expected, or as I expected going into this, just from my own experience, systems level barriers were by far the biggest barrier to diabetes technology use. So on the survey, almost every single provider reported that lack of insurance coverage, despite meeting eligibility or excessive copays, was a barrier. So issues with either having insurance or just having very high copays despite having insurance. And this was the biggest barrier to regular use reported by almost half of providers. Similarly, the cost of the device was a barrier reported by 75% of providers and the biggest barrier for a quarter. Excessive bureaucratic barriers to obtaining insurance coverage, including prior authorizations. If you're not a provider, maybe you don't know about all the paperwork involved in prior auths, but it's insane. If you are a provider, you understand. And then bureaucratic barriers to determining the appropriate pharmacy versus durable medical equipment provider. So this is sort of a niche barrier specific to medical devices and equipment, but many DME suppliers are not integrated into Epic or the electronic health record. And so we can't actually e-prescribe a lot of these technologies, and they have to be faxed. And so this was a big barrier identified by over half of providers. And finally, a lack of clinic infrastructure to use CGM data or access CGM samples in clinic were reported by a quarter of providers. And this is, despite these being very highly specialized providers and large group practices, a lot of them still had issues with a lot of these infrastructural barriers. In terms of pump use, it was very similar. Lack of insurance coverage and cost were the largest barriers. Bureaucratic barriers to obtaining coverage were very common, but slightly less reported than CGMs. And perhaps, again, this is because the ADA criteria has expanded a lot for CGMs, but is a little bit narrower for insulin pumps. Similarly, barriers to determining appropriate pharmacy versus DME were still commonly reported, but a little bit less so than for CGM. And I think that is probably because pump companies often assist with these processes when you prescribe an insulin pump. But when you prescribe a CGM, those types of companies are not as directly involved typically. For the interview results, so 65.7% of codes were related to systems level barriers. So this was a huge, huge issue. And this was encompassing health insurance, EHR platforms, pharmacies, medical device companies, DME suppliers, and healthcare institutions. And, again, this is just a really big issue for a lot of providers. Some examples of this, again, were high copays, even when technology is covered. And then the convoluted process of navigating through durable medical equipment companies, insurance companies, and the clinics with many opportunities for communication breakdowns. And it was interesting because clinics had different solutions for this. So some of them really tried to handle the whole process themselves, but frequently would still have communication breakdowns where, the patient would show up again 3 months later for their follow-up, and the provider would be like, oh, did you start your insulin pump? And they, found out there was basically like a missed fax somewhere where they couldn't actually, they hadn't gotten through the process because the communication just had broken down. And then other clinics tried to put some of this on the patients more, but found that, understandably, patients don't understand the process because it's very complex and difficult to navigate. So they don't understand their insurance. They don't really understand DME companies. They don't want to do all of the legwork. And in some people's opinion, this should be part of going to the doctor's office and getting an insulin pump or CGM. Not that they have to call their insurance, spend time on the phone, try to figure it out, all these new terms. And then they said this is a 3-month process is what it turns into. So again, whether it was more on the clinic or on the patient, it frequently, there were communication breakdowns through this convoluted system that we have. Clinician participants in our study identified insurance issues as the most important barrier to prescription of diabetes technology, especially when thinking about at-risk groups. So this included, again, A lack of coverage information in the EHR. So when we prescribe diabetes technology, a lot of times there will not be any information on whether it will be covered or not. And if it is in there, sometimes it's not accurate. High copays and deductibles for patients, at which we also don't know whether they're going to have a high copay or deductible. And then insurance eligibility requirements came up quite a bit too, that were not in accordance with ADA standards and could be a barrier. So these frequently included disease duration stipulations. So although it's not in the ADA criteria that you have to have diabetes for 6 months before you can have an insulin pump, that can be an insurance criteria. Requiring glucose logs that maybe the patient has, but they forgot to bring in, or maybe they just didn't do it. Excuse me. Diabetes education and visit frequency requirements, and other just documentation requirements that maybe even if the patient has fulfilled these requirements, just the documentation isn't there. And all of this can, again, be influenced by communication breakdowns. The prior auth process and bureaucracy surrounding these requirements takes hours of time and effort, especially since these are frequently done via fax. We're back in the 1980s with our faxes. I found this interesting. There was one survey study done by the American Medical Association that showed that 33 prior auth requests are completed per physician per week, and the average medical practice taking up 2 full business days of work per week. So frequently if this process is not going well, it can lead to treatment abandonment for patients, especially in those who don't have the time or resources to advocate for themselves. Like I mentioned before, the inability to prescribe to durable medical equipment companies through the electronic health record, although it's a little bit of a niche barrier, this is diabetes, which affects, 1 in 10 Americans. And so it's a big problem for people with diabetes who are prescribed CGMs and insulin pumps, because we often cannot prescribe durable medical equipment, which these, qualify as durable medical equipment through the EHR, and have to fax things. And it's frequently difficult to figure out which company is preferred by the insurance company. And so, it's just a huge issue for a lot of clinics that may not have the infrastructure to deal with this. I like this quote: "The sheer amount of man hours just with people standing in front of scanners and fax machines is absurd to me." And they said this inability to prescribe DME through the electronic health record also hinders efforts towards usable and accurate prescription benefits in the EHR. And so we can't, frequently see if some of this has been prescribed, because, that's how we track things, is through the EHR, but this is not done in the EHR. So it's paperwork that has to then be scanned in later. And then, usable electronic prior auths as well. So if we wanted to do a prior authorization through the electronic health record, if we can't have, DME companies integrated into the electronic health record, it's difficult to then do the prior authorization in there. So there is some hope for change in these areas, which, it makes me happy. Recently, electronic real-time prescription benefit tools have been implemented as part of attempts to support and streamline electronic prior auth. And so basically, when you pull up the prescription for a patient, it will actually tell you if this is going to be covered by their insurance. And that has gotten better over time. And we're working towards being able to do prior authorization. Some places you actually can do a prior authorization through the electronic health record, but that is an add-on and not able to be done in every institution. And, information on the preferred supplier, so either the DME company or the pharmacy, is not currently available in the electronic health record. So we don't know whether your insurance company prefers CVS or Walgreens or, whichever supplier it is. And so that would be very helpful, but is not currently widely available. Electronic prior auths, again, through the EHR would be helpful. The clinicians thought that these would be helpful, but as with all of these tools, usability is key. So it would be best to be standardized across insurance companies and automatically populated with clinical information. So, artificial intelligence is the newest and greatest thing that we're all working on. So being able to populate some of these things, either using artificial intelligence or just rules-based automation, would be very helpful in terms of filling these types of things out. We need to have a record kept of prior submissions and all information exchange occurring through the electronic health record to optimize efficiency. This is all possible. The electronic prior auths are, including this sort of automatically populating them is possible using existing technology, but is not widely done yet. But there has been a recently finalized CMS rule that's going to require all publicly funded insurances to make electronic prior auths embedded within the EHR. And this will be available for diabetes technologies beginning in 2027. So stay tuned for that. And then again, the obvious solution to the lack of DME integration is to require this, but that is not yet on the horizon. There are companies that provide electronic DME prescription services, and these include Parachute Health, DME Scripts, eOrders Plus, and Go Scripts. I apologize if I missed any, but these are the most widely used ones that I saw. And these companies can integrate into the major electronic health records, but they do so at a cost. And so a lot of institutions have not opted to integrate these types of services into their electronic health record. But I do think this is a very important thing that should be done. We had some other interesting results found in the study. So pediatric providers more frequently reported patient and caregiver level barriers, while adult providers tended to more frequently report clinic and system level barriers. This may be due to the larger type 1 diabetes focus in pediatric clinics, with the accompanying infrastructure and personnel who can focus in on really a lot of these systems level issues and hire more people to deal with it and have some more dedicated infrastructure to deal with it. Additionally, there have been previous studies that show that pediatric patients have specific concerns about adhesives and skin issues, and also visibility of diabetes devices affecting physical activity in terms of the skin issues, and peer relationships in terms of the visibility. And so this also may be why some peds providers focused a bit more on the individual level barriers to diabetes technology. However, these barrier differences were pretty small. And overall, peds providers still did report a larger systems level barrier issue than anything else. But in terms of proportions, they tended to report a bit more individual level barriers. But the takeaway for this is that if we target different levels of the social ecological model in terms of solutions to these problems, it may affect pediatric versus adult clinics to different extents. Another thing that I mentioned briefly before is that patient not interested was reported more commonly for insulin pump use than continuous glucose monitor use. CGM is increasingly viewed as the standard of care for people with diabetes on insulin. And so, the 2025 standards of care is the first to say that artificial insulin delivery systems are preferred for type 1 diabetes, are the preferred method for type 1 diabetes. And so patient preference does still play a key role in insulin pump prescribing and usage. But this may require, again, a mindset shift in terms of providers of diabetes technologies, because now we should kind of be thinking of AID systems as the standard of care as well, especially in type 1 diabetes. And so, while this is still going to be a shared decision-making model, we really need to emphasize the benefits of these systems to patients. As mentioned earlier, 44% of providers felt that health literacy barriers and associated safety issues warrant the decision to not prescribe diabetes technology. And in my opinion, I'll kind of go through the history of the ADA standards of care a little bit, but I think that the standards of care have reinforced this view. So I did a little screenshot. It's a little bit of a history lesson, but in 2019, the first diabetes technology section of the ADA standards of care was released. So if you just think about that for a second, we've only had a technology section of the standards of care for 6 years. So we have come so far in diabetes technology in just a span of 6 years of it having its own section of the standards of care. The 2019 standards of care said that CGM should be considered, but the benefits of using technology correlate with adherence, and CGM is only a useful tool when used properly. So this language, sort of emphasizes the importance of adherence and using it correctly, which may have made providers a bit hesitant to prescribe it to people who they would be more concerned about these specific issues. So we went from these qualifying statements in 2019 to then saying in 2022 that CGM should be offered, but only to those who are capable of using CGM safely. And then finally, in 2025, the standards of care recommend CGM for everyone with diabetes on insulin with no sort of safety qualifying statements or anything like that. And so I think, the previous qualifying statements may have contributed to some disparities in tech prescription, since we know that implicit bias and even cultural and language barriers can influence who providers feel can use technology safely. So I'm glad these types of statements have been removed in the 2025 standards of care. We still need to get the word out that all people with diabetes on insulin should have access to this important tool. In terms of insulin pumps and artificial insulin delivery systems, they've had the same sort of issues as CGM, but are perhaps a couple of years behind where we're at with CGM. So in 2019, the standards of care stated that most people with type 1 should be treated with intensive insulin therapy, and that could either be injections or pumps, and AID systems may be considered. So it kind of gave you the whole option. That's kind of what I was trained. It was sort of like using injections versus a pump is kind of like choosing a model of a car. Like the car will still get you there, but you have preference in how you select a car model. And that's really, I think, because AID systems were not as widely used then and were kind of new and up and coming. And those really have changed and kind of revolutionized diabetes care. And so in 2022, it stated that AID systems should be offered to those with insulin deficient diabetes who are capable of using the device safely. And then in 2025, they removed the word safely and then just said capable of using the device. And then also, like I said for the first time that AID systems should be the preferred insulin delivery method for those with type 1 and should be offered early. So we've come a long way in a short period of time in terms of how we're phrasing this. But I think because things have changed so rapidly, it's going to take some work on our part to get this message out to all diabetes care providers. And then just to answer the question of who can use AID and insulin pumps safely versus multiple daily insulin injections, right? Because that's the options really. When we have people with diabetes on insulin, we can't, make the insulin itself go away. Like they have to use insulin, which inherently is not, it's definitely a medication that comes with some risks. But in terms of, AID and insulin pumps versus shots, what is the difference there? So far, there have been 3 different studies showing that AID systems are safe to use and improve hemoglobin A1C without increasing severe hypoglycemia or DKA in youth who have A1C levels above 10. So we have 3 good studies there that show it is safe to use in youth with high A1C levels. Another study was recently published that I thought was very interesting of 30 type 2 diabetes adults who actually required home health care because they were not able to manage multiple daily insulin injections on their own. And they randomized these adults to either receive AID systems or keep them on multiple daily insulin injections. And the group on AID had an increased time in range of 27% and a decrease in A1C by 1.3%. Without any instances of severe hypoglycemia or DKA. So, this is really sort of a mindset shifting study to me as well. All of these studies were either published in 2024 or 2025, so they are newer. And I think this issue should be studied more, and as more studies are published, I hope we can continue to expand the populations of people who we think are capable of using AID systems. And another study of clinics with either high or low insulin pump use. So these clinics were pretty similar in most of their demographics, but one clinic had very high insulin pump use, while one clinic had a very low insulin pump use. Viewing insulin pumps as just another care delivery system rather than a liability increased the prescription and use of insulin pumps. And this was one of the major factors in what was driving these sort of differences in who was prescribing insulin pumps. And then another two qualitative studies. This was after a randomized controlled trial of one of these high risk, youth with elevated A1C studies. And so they interviewed the staff on these studies, and really seeing these high risk patients do well on artificial insulin delivery systems improved those providers' perspectives on prescribing technology to more high risk groups. So finally, to conclude, there are multi-level barriers that exist to the prescription of diabetes technologies. The most common barriers faced are related to the U.S. healthcare system, including cost to the patient, inability to evaluate coverage and preferred supplier in real time, a drawn out and opaque prior auth process, and DME suppliers not being integrated into the electronic health record. Barriers to use of diabetes technology is viewed from the social ecological model are interconnected. So for example, a patient with higher health literacy and no language barrier can often better advocate and navigate communication breakdowns between these systems of care. And these interconnected barriers do increase health disparities. The good news is improving barriers at one level of the social ecological model should also improve access to care at other levels. And I'd like to thank my mentors, collaborators, and funders, and the Georgia Center for Diabetes Translation Research, both for the funding and the opportunity to present this work. Thank you so much.
Thank you, Brittany, for the presentation. Really, really good. I was really looking for it, and then that's really nice. Now we have some time for questions. Thank you for leaving some time for questions as well.
Yeah.
If you prefer to put them in a chat, I can read them out, read them also from the chat, whatever you all prefer.
Hello, this is Sadia Hassan. A wonderful presentation. Thank you. As a primary care physician who's trying to prescribe more of these continuous glucose monitors, this was very helpful to see. A couple of barriers that I encounter that I didn't see come up. So one is that I have several patients where the app is not compatible with their phone. So I don't know if that's come up, especially my lower income who still have their Obama phone. That's been an issue. And then for those who have the meter, so they don't have the phone, but they have the meter, they still forget the meter. Mm-hmm. So then I can't upload the data. So any thoughts on those barriers and what we might do to overcome them as well would be great.
Yeah, yes, that definitely did come up. So the phone, I think actually I didn't mention it in my talk, but it was maybe in my little diagram that I had going on. But yes, the non-compatible phone definitely was an issue. And then, yeah, when, you can prescribe the receiver thing, basically, that you can use with it instead of a phone. But that not only makes integration with the pumps a lot harder. So if you have somebody who qualifies for a pump, it's hard to integrate without the phone. The phone is really key. We basically tell patients you have to have a phone that works. And, for a lot of people, it's impossible for them to get a phone that works. So yeah, it's a huge barrier. Yes, I don't know if I have a great solution other than, prescribing the receiver is better than nothing, especially, if they can't get a compatible phone. And then sometimes there's random grant opportunities to get phones for people, but it's few and far between. So it, like I think during COVID, we got this technology grant from the government to provide some compatible phones to people. It was part of this larger like broadband network, grant. But that grant is gone, and now we don't have anything. And so, yeah, it's tough. I don't have any good solutions other than trying to fight for people to have access and, raising the issue, definitely. Sorry, what was your second part to that again?
No, I think you answered it all in one. So thank you. And then my only follow-up is if are you using this information now to design a multi-level intervention maybe, and what your next steps are?
Yes. Yeah. So we're trying to finish up the second part of the study. And, initially my thought was to design some kind of a tool to use in the EHR. And so definitely like using smart sets and those sorts of things, would be helpful. But honestly, a lot of these are big system level barriers. And so, and we did submit this for publication. And so kind of a little bit of a call to action from some of these key healthcare players to improve their systems. Because I think, smaller tools that we can create on sort of the clinician level can be helpful, but we also need to work with these larger systems. And, like Abbott actually recently announced that they're integrating CGM data into Epic. So that, is a nice progress point there where we can actually see the CGM data in Epic rather than having to like log into the Libre and then have all these tabs open everywhere. So yes, I think, for sure we are working on some of that, but also working on, advocacy is another big thing that I like to do. And so advocating for some of these bigger systems to make things better too.
We have some comments, discussions on the chat. Brittany, you want me to read them or you want to go through them?
You can read them. So we,
Okay.
Darren Olson.
Yeah. Okay. Okay. So I'll read them. So that's from Darren Olson. And the chat messages that the health system barriers identified within specialist clinics are even greater in primary care and rural settings. In fact, nearly impossible. How to translate or implement outside of specialty settings?
Yeah, so the ADA is having a big initiative to work with primary care providers on some of these issues because, like I did mention, these interviews were with highly specialized clinics, and if we're seeing these problems in these clinics that should have like the optimal infrastructure for this, like now think of the primary care provider who's managing a million different issues and doesn't have the time or money or ability to invest in these sorts of solutions. So I think some of these things would be translatable. So like, for example, the bigger systems level solutions that we can advocate for. So electronic prior auths, would be very helpful for primary care as well. Integrating DME into the electronic health record. Having some of these CGMs better integrated into the electronic health record. Smart sets, honestly, are helpful for both specialists and primary care providers because updated smart sets where you can just select, the Libre 3 sensor and then the Libre 3 receiver and like how much of it should be prescribed and like where we should prescribe it. So those sorts of things I think can translate across different settings. But some of these disparities again are just going to be even higher in the primary care setting. And then the second question, let's see.
Yeah, the second was the gist of this to the system is the missing stakeholder here. And I have recently listed my jobs in rural setting that was not willing to absorb this cost. Who will pay for this cost?
Yeah, so some of the issues, especially at the systems level, it's funny when I talk to insurance companies. So I bring these points up to insurance companies sometimes in terms of prior auths. And I work with the AMA, and like I said, I do a lot of advocacy. And insurance companies are like, oh, well, we want to make your life easier, and we want to make things more efficient and run more smoothly. I'm like, do you? Because, then you have to cover more if things are easier and more efficient. And I don't know if that's, so maybe that's the cynical point of view. But I think some of this honestly has to be regulatory a little bit. So like I said, that CMS rule will go into effect in 2027, and it requires electronic prior auth. And so I think, the AMA has had a lot to do with that and trying to fight for clinicians to make things a little bit easier. But some of these things are not, it depends on the cost to who. So if it's the cost to the insurance company but the cost to the healthcare system, some of these interventions would actually improve the cost to the overall healthcare system by making things more efficient. So reducing some of these red tape things and bureaucracy would improve maybe the cost to, especially like the government, Medicare, Medicaid, and that sort of thing. But maybe not the cost to everyone. And so just trying to get incentives aligned and get us all on the same page and try to improve things for patients. It's what we're here for. So yeah, could be a whole different talk, but yes, the costs, for sure, if we could do things on a wider scale, I think the better. But some of the things like, again, smart sets, some of these smaller interventions, don't necessarily incur a cost and can still make things more efficient. So doing just some little quality improvement type work within the clinic can also, so the type 1 diabetes exchange has done a lot of quality improvement work among their clinics, and they've really been able to improve some of these outcomes without incurring a lot of additional costs just through quality improvement.
Great responses, Brittany. Thank you.
Okay. Thanks so much. I enjoyed it. Thanks, everyone.